Good morning. Welcome to this third live webinar of EFIM. My name is Nicola Montano. I'm the current president of EFIM, and I would like to thank you for joining us this afternoon. This is our third live webinar. We have two previous webinars in which we discuss about what happened in different countries during this COVID-19 emergency. Now today, the idea is to look for lessons that we have learned during the last 3 months in order to be ready for a possible, or at least something that we have to be prepared to as a second wave, and so to have learned and how we could differently manage the COVID-19 virus. The panelists today will be Professor Xavier Corbella from Barcelona, who is the General Secretary, Professor Runolfur Palsson from Reykjavik, who is the past president, Professor Dror Dicker from Israel, who is the president-elect of EFIM, and last but not least, Professor Kokorin from Moscow, who is our secretary. And so we will briefly focus on 4 arguments from healthcare to risk factors very briefly. So thank you very much. And before giving the podium to the speaker, let me just provide you with a few technical details. So at the end of any talk, there will be the possibility to ask a question and answer 2 or 3. And I would like you to use the Q&A box that you can see in the banner at the bottom of the Zoom screen. And so you can write there, and the question will be available only to the presenters and not to the attendants. Please, of course, mute your mic while we talk in order not to have noise. Okay, let me just provide you a very brief overview. And as an overview, I would like just to show you one thing. That is this paper that was published, as you can see, on Science, Friday, May 30, 1919, so 101 years ago. And the author of this paper is the Major George Soper, who was the surgeon attendant of the Army, of the US Army, and was the character that could be now compared to Anthony Fauci for US. So the person that was the most important and influent person in the task force of the Spanish flu. Yeah. And what is nice that if you read this paper, you may think that it has been written yesterday, because all the things, all the lessons that they have learned are exactly the same that we have learned now. So we have just replicated what had been observed more than 100 years ago. And you can see here are the decalogue of what they have learned. And you say, avoid needless crowding, because influenza is a crowd disease. Smother your cough and sneeze. Others do not want the germs which you would throw away. Your nose, your mouth was made to breathe through, get the habit. Remember the 3C, clean mouth, clean skin, and clean clothes, and all the rest. So most of the public health lessons were already known. But there are many other things that in 100 years happened. So our hospital changed completely. We have, of course, we have drugs available that we didn't have before. Now there are our lifestyles are completely different. So, of course, our possibility to impact on COVID has been at least more Not efficient, because still we don't know how efficient it was, but at least we had more possibility to act. So today we are here just to briefly discuss about 4 topics and to see in these items, healthcare organization, drugs available, risk factors, comorbidities, what we have learned and what we have to take care of if we have another wave. So thank you very much. And now I would like to leave the podium to the first speaker. First speaker is Professor Xavier Corbella, and he will talk about healthcare organization during the COVID emergency. Please, Xavier.
Thank you. Good afternoon, everyone. I want to share my screen on, well, excuse me.
I think you're at the end of the slideshow.
Okay. My computer is very slow. I think that, Nicola, in 1919, we were not there. Because in Spain, I think that it seems that we forgot all the lessons learned during the Spanish pandemic. Because as you know, we have been the country second only to the US during many weeks in this pandemic. Now we are in the 4th or in the 5th position, but almost 300,000 people have been infected in our country. And the first patient arrived or was declared on February 25th, when in Europe, only 1 week before was confirmed to arrive the COVID pandemic. Here you have our curve of our cases. Now we are it seems that we are at the end of the curve of as other countries in Europe. But what I want to share with you is what happened, and in parallel explaining what we did in healthcare organization and what we learned. The first 2 patients at Belviche University Hospital were admitted on March 12. Here you have, we were alerted, and especially we as EFIM executive committee, because Nicola suffered the pandemic in the beginning, and we were in touch, so we were waiting for the arrival. But very fast, in only 1 week, we had 121 patients admitted. And here you have the distribution according to the hospital care setting. And almost half of them were admitted in the semi-critical or critical care units. Here is 7 days after the beginning, 78 patients admitted in the conventional wards, and 19 in non-invasive units with the most specialists involved as the pulmonary specialist, and at the intensive care unit with invasive ventilation and patients intubated at that time was 24. So we immediately decided to plan our actions, and the first step that we decided to do was to create the structure for planning for the decision making. This is the first very important step that every organization have to do, not to start with protocols or deciding how to supply equipment. But first of all is to create the crisis committee, to create the structure for the decision making. And this is an image of our team the first day that we met. Of course, people were still wearing clothes, normal clothes, but immediately the day after, we changed completely our behavior in the hospital. So this crisis committee was formed by different kind of people. Hospital executives, for sure, basically the chief medical officer and the chief nursing officer, but multidisciplinary rest of members representing different parts of the hospital, most of them belonging to medical services, most involved in the direct delivery of these patients, the emergency department, internal medicine, infectious disease, intensive care medicine, anesthesiologists, and other kind of healthcare providers, like of course nurses, and some people of the basic laboratories like microbiologists, etc. This committee met every day in a short morning early meeting to know what happened the day before. The meeting was at 9:30, and in only 30 minutes, all members knew what happened and what was the situation of the hospital every day, and what were the needs for the day, to open more units, to involve more professionals, to update the protocol, etc. The next step was to create and to written the plan, and deciding which elements will be part of this plan. The worries was patients, so the first was to create the algorithm to know what will be the protocol to manage COVID-19 patients. But other interesting issues have to be addressed in these plans. What will be the activity of the different services? You know that most hospitals arrive to cancel non-COVID activities, so you have to decide which activities is priority for you, and what will be the surge capacity in those patients severely ill with cancer, etc. The third issue is healthcare providers. Healthcare providers are a key point in this crisis, not only to have the enough number of them, but also how to educate them in a more polyvalent and more flexible tasks, educating physicians that normally don't take care of this kind of patients, like neurologists or cardiologists or a gastroenterologist. So it was a huge task to supervise and to give support to them. And of course, protection was one of the worries that we didn't have enough material at the beginning of the pandemic. So how to provide individual protecting equipments. All the team taking care of the infection control and preventive measures, and also occupational health, because you know that all the contacts at the beginning is very important to isolate. Then when you are at the center of the epidemic, is not so important, but at the beginning you can delay the spread with a good occupational health policies. And then to decide the facilities, the equipment, the supplies, the consumables. This has been a very tough task to provide respirators and all these materials that COVID patients needed at the time. And finally, one important aspect that we learned, and all of you that have been involved in this pandemic, is how to take care of our patients that are alone, admitted without the relatives, how to decide the visitor access policies, how to manage the emotional pressure against providers taking care of these patients without their relatives, and only a very cold call that you can inform the families about how is evolving the patient. These are some pictures of our hospital. The first one is the main hall of the outpatient clinics that we allocated 50 beds in advance to be needed if we decided to empty the hospital to have more space for intensive care. And this was thinking those patients that were at the last days of the admission and preparing for discharge. But this has been the image of our main hospital, main hall of the outpatient clinics. 85% of activity was dedicated in the center of the epidemic to COVID patients. We had the luck that we are moving on a new building to have new operating rooms, new intensive care unit beds. So we had old operating rooms empty, and we decided to readapt it to allocate more conventional patients. So all the technicians providing the oxygen support and all people working for very fast for face the pandemic. This was the evolution of our pandemic. So you have to, of course, follow this action plan, but at the same time managing the pandemic. And this has been really a tough task, working on weekends or working on Saturdays and holidays, days and nights. And this was the peak of our pandemic with more than 600 patients admitted. Finally, this action plan has to provide follow-up of all these decisions, how implemented in the reality, and how to monitorize and evaluate the results. So it's the typical circle of decision making, and you have to analyze the current situation, the priorities, planning, etc. Finally, my two slides are planning the post-COVID action plan. Now is our worry and our challenge is how to face the recovery of the normal activity of the hospital. And we are planning at different levels, the lessons learned. One is the micro level. The micro level is patients and healthcare providers. We are in a new era. Our relationship and our on-site visits probably will be reduced. So we have to decide what will be our kind of activity in the future. At meso level is how to recover the non-COVID-19 activity. At macro level, I think that we have to think and to ask about how to finance this, because it will be more expensive, our delivery from now. And for internists, I think that most of us have led the pandemic in our hospital. So it has been an opportunity to lead and to innovate. So we don't have to leave this as a loss. So thank you very much. I am open to your questions or your comments, and of course the final debate to participate in any case. Thank you.
Thank you very much, Xavi. Yeah, healthcare organization has been quite challenging. So far, since there are no still questions, may I ask you, what would you modify, now in terms of healthcare organization, if you should have to forecast another epidemic, another pandemic, okay? Not necessarily a second wave, but to be ready, what should you do? Would you dedicate specific, for instance, hospital to COVID and other totally trying to get other totally free? What kind of different things now you should do?
Thank you, Nicola. I think that this is our challenge now, to how to imagine our future activity. And as you said, one of the lessons is to prepare the hospital to be flexible and to change in a very few time, converting probably conventional wards to intensive care, for instance, to have enough spaces to be modified in very few time. Imagine a daycare hospital that can be converted to an intensive care unit, and to decide to protect the normal activity, because one of the problems that most of us we had is that we canceled completely the normal activity. So we have to protect the other patients. So cancer patients waiting for chemotherapies, patients waiting for some important surgical intervention. So it's clear that we have to divide the hospital in a contaminated part and a non-contaminated part. And for us as physicians, we learned that we have to be more polyvalent. And as internists, we are now taking our future learning how to manage non-invasive ventilation, how to manage ultrasonography, how to manage and being more helpful for the organization and to change rapidly. So from these 2 points of view, spaces, organization, yes, I am totally agree that you have to be prepared to divide the hospital, to be flexible and to be polyvalent, to adapt very fast to these new pandemics that can arrive.
So thank you very much, Xavi. Another very small question. You mentioned the DPI, and you know, for us, but I read that in almost all countries, this has been a real big problem at the beginning. And mostly the diffusion of the infection through the healthcare workers has been related at the beginning to the lack of supply of the DPI. So maybe do you think that also our healthcare managers should also have at this point and maintain an important supply? I mean, we can understand that, of course, this could imply, you know, a lot of space for storage and other, but DPI maybe are another key point in this. What do you think?
Yeah, I think that all of us realize that our factory is in China. So one of the reflections is to create the infrastructures that these basic elements to manage these very, very complex issues and dangerous issues have to be assured, produced by ourselves in our countries. And from this point of view, I think that the DPIs could be one of the perfect examples that you can storage in a central storage from different regions, but producing and assuring that these will be enough to manage in our local settings. Of course, one of the worries have been in the middle of the pandemic that we had no enough material. Now I think that this has been an important lesson to protect. But in any case, we studied our personnel, and I don't know your experience, but in our case, is almost 10% of people that have been infected among healthcare workers, not more. We don't know if the equipments worked well, or if the pandemics is still not well known how it runs. But the reality is that only 10% have been detected positive, and 90% of our professionals have been negative. Our current population is around 95% negative and 5% positive.
Yeah, we have a positivity, but almost the same. There is another question, Xavi. So one attendant asked whether your hospital was completely dedicated to COVID, or you maintain also other pathways for non-COVID patients, and how did you organize these different paths?
Well, at the center of the pandemic, we canceled all activities. It was the first time we were totally lost, and we couldn't decide better. Now we are recovering the activity, and we are creating these different paths. Of course, any scheduled patient have to be tested 24 hours before being admitted to assure that is PCR negative. And all laboratories and equipments are now deciding which part is reserved for COVID patients and which not. The problem is that the waiting rooms, the speed of patients that could be visited is quite slow. You have to reduce the number of patients that you can visit because you have to take some control and preventive measures. So in any case, is extremely difficult to maintain the same speed of activity that we had before. So we have different circuits, but we are very worried about, we have, for instance, we have 3,000 endoscopies waiting. So these patients, that are 3,000 patients in our hospital waiting for a colonoscopy, how we will manage this is extremely difficult now to imagine how to do that.
Thank you very much, Charlie. Now there is another question from another attendant, but it's a general question about pharmacotherapy for all of you, for all the speakers. So I would like to move this question to the general, because it's directed to all the speakers. So I would like to move this question to the general discussion later on. Okay, thank you very much, Xavi. So let's move on now with, and the podium goes to Professor Runolfur Palsson now. And Professor Palsson will talk about the in-hospital treatment and what we have learned.
Thank you very much, Nicola. Can you hear me well?
Yeah.
Okay, so please move the slides for me. It's been a very interesting experience, you know, managing this pandemic and patients in the hospital with respect to treatments, because, I mean, we have been frantically looking for effective therapies, and there have been a number of agents available on the shelf, so to speak. For instance, antiviral agents, and we've been using those even if they haven't been tested, of course, in these patients. And it's been quite an experience. So can you move the slides for me, please? Or can I do it myself? And the next one? The next one, please. This illustration, no, please go back one. This illustration, unfortunately, you may not be able to see it well, but this illustration is from a paper that just came out from a Chinese group, and basically depicting the mechanisms of different therapies that we've been applying so far. And interestingly, hydroxychloroquine, the agent that we've been using for immune-related disorders, came up relatively early, and due to the fact that it was shown to have, it's known to have an antiviral effect. And I think this agent has been used in most countries to treat COVID-19, and we did that for sure. The focus has mostly been, though, on antiviral agents. You know, the HIV protease inhibitors, lopinavir, combination with ritonavir, and then remdesivir, which has really been has held the most promise, as well as favipiravir. And so, these agents have been used in certain centers where they've been available. And then another focus has been on the hyper-inflammatory state that you all know is frequently seen among the sickest patients. So using immune suppressing therapies, for instance, the IL-6 receptor blocker tocilizumab, IL-1 receptor blocker anakinra, for instance. So these agents have been used quite a bit, particularly tocilizumab. And then the third kind of strategy has been using neutralizing antibodies, almost only in the sort of form of convalescent plasma from patients, but now hyperimmune globulins are being developed. So these three strategies have been used all along, but we needed trials to test how these agents work. And fortunately, and this has been one of the most enlightening sort of experience in the past few weeks to see some of these clinical trials come out. Next slide, please. I mentioned previously that remdesivir, a nucleoside analog, held the most promise based on in vitro studies. And this paper came out in the Lancet at the end of April, basically testing in a randomized controlled fashion remdesivir in patients with severe COVID-19 and from China. And the primary endpoint was basically time to clinical improvement. And unfortunately, there was no difference between remdesivir and the placebo group. But unfortunately, the trial ended earlier than expected because they ran out of patients. I mean, this was at the end of the outbreak in China. Next slide, please. But this was followed by a study, NIH-sponsored study, that was run in the US, but with participation from hospitals all over, and basically looking at remdesivir in more than 1,000 patients. And actually, this trial was stopped early because the safety committee noticed that there was difference. And basically, you can see that the effect of remdesivir was overall was positive, and particularly in a group of patients that required oxygen. It was really driven by that particular group. But overall, and I think the beneficial effect was reflected in a median time to recovery of 11 days in terms of instead of 15. So it was really a modest effect. It was really a modest. There was a trend towards improvement in mortality, but there was no statistical difference there. And here, next slide, please. So here's another figure actually coming up that shows that the median time to recovery was significantly shorter for remdesivir. Next slide, please. Another trial, and this is a study carried out in China as well, tested lopinavir, ritonavir in hospitalized patients with severe COVID-19, and they enrolled 237 they enrolled, I believe, 200 patients, and unfortunately there was no difference, but the treatments were introduced late in the course, so it's difficult to tell, but clearly there is no major effect there. But the patients were sick, and the treatments were started late. Next slide, please. Now, what about hydroxychloroquine? Well, I'm not going to spend much time on this. There have been several trials published already, and in short, there was no benefit from hydroxychloroquine, or neither was there for chloroquine. and unfortunately, the rate of adverse effects was much higher, significantly higher for hydroxychloroquine compared to placebo. Next slide, please. Here's another study, actually from Brazil, testing high doses of chloroquine and testing high doses of chloroquine compared to low doses. High doses, about 12, I guess it was 1,200 milligrams every day for 10 days, whereas the lower dose was a loading dose of 900 milligrams followed by 450 milligram daily. And here you can see the survival probability, and it was significantly lower for the high dose. So there is this notion of basically adverse outcomes on those who receive higher doses of these drugs. And we know, all, of course, about the prolongation of the QT interval. Next slide, please. There are ongoing trials testing tocilizumab. Unfortunately, until now, there have only been case series and individual case reports. And this case series was published in the European Journal of Internal Medicine, coming out of Italy, where 85 patients were treated with tocilizumab. And unfortunately, the control group consisted of patients that were treated before the drug became available in the middle of March. But this is not a controlled study. I mean, this is just an observational study. There was an obvious benefit of tocilizumab in terms of cumulative survival, that you can see on this figure, but we cannot draw any conclusions from that study, unfortunately. Next slide, please. Finally, convalescent plasma or hyperimmune globulin. This is a review from the Cochrane library on these treatments, on reports that have been published so far. And we know that this has mostly been done in the United States, and they've treated more than 500 patients using this therapy. And unfortunately, there are no good studies available, mostly only case reports, case series, and they came up with only 32 patients in this review, and we cannot really conclude anything about the effect of neutralizing antibodies so far. But there are ongoing trials. Next slide, please. There are numerous clinical trials ongoing, and I think this is one of the positive things we can take from the pandemic. I mean, I must say that early on, I mean, we were really shooting from the hip. I mean, based on some, obviously, at least the available in vitro evidence on viral effects of some of these medications. But we have initiated around the world numerous randomized controlled trials. And there are two very large trials ongoing, the Solidarity trials that is being run by the WHO, testing remdesivir, the combination of lopinavir, ritonavir, and then the combination of lopinavir, ritonavir with interferon beta 1A. Hydroxychloroquine was one of the arms, but that has now been removed because of the studies that have come out so far, and really showed that the drug doesn't really have any benefit and associated with adverse outcomes. And then the recovery trial in the UK, testing multiple arms, lopinavir, ritonavir, low-dose dexamethasone. And by the way, corticosteroids have not really been shown, there's no real indication that they are beneficial. Hydroxychloroquine, which has not been removed from that study. Azithromycin, which has been used together with hydroxychloroquine in many centers, tocilizumab, and then convalescent plasma. Next slide, please. This is the last slide. I mean, based on the current evidence, I mean, how should we treat hospitalized patients? Well, in my view, remdesivir, if there's severe disease, but we need to initiate the treatment early. And remember that the effect appears to be modest, but in all likelihood, it would be beneficial to initiate the treatment earlier, sooner than later. And then just general measures, cautious intravenous fluid replacement, pharmacologic prophylaxis of venous thromboembolism, critical care management. I mean, all of these things, they matter. But finally, and last and not least, enroll patients in randomized controlled trials if it's possible, because that's the only way we have to gain knowledge about the available treatments. Thank you very much.
Thank you very much, Runolfur. Very clear. So we are building up evidence, because so at the beginning we have no single evidence. Now we are building up, and so we will be maybe more prepared in the future. There is a question. About the flu vaccine. So one attendant is asking whether is there any evidence that those who got vaccinated with the flu vaccine have a more severe COVID disease, so have a probability to have a more severe disease, or whether there are any data about this?
Not that I'm aware of. I mean, this is a enormous literature that has surfaced in the last few months. And then I obviously didn't mention, vaccines in general are very, exciting. I mean, there are numerous vaccines being developed, and the word is that these vaccines will be available sooner than we expected because of the collaboration of the FDA in the US and the European Medicines Agency in Europe with investigators that are developing these vaccines. So the path to clinical use will presumably be faster. But in terms of the flu vaccine, unfortunately, I'm not aware of that.
Okay, so I think that we can move on to the next speaker. And the next speaker will be Professor Dror Dicker. Professor Dicker will talk about the patients, and so the risk factors are developing a more severe COVID infection. So the relationship between individual risk factors and outcoming COVID infection. We received other two questions, and I will postpone the answer to these two questions for the general discussion. Thank you.
Okay. Good afternoon, everyone. Good afternoon, Professor Montano. Thank you for the honor and privilege. And I want to really concentrate on the comorbidity. And I will concentrate in my talk on diabetes and obesity. You can see here the high percentage of patients with diabetes or patients with obesity that were hospitalized during the COVID-19 epidemic. And in fact, obesity is as high as hypertension as a risk factor. And you can see also that diabetes is a very high risk factor. So let's start with diabetes. In one of the cohort that in my department, we looked on the gender difference in the prevalence of risk factors. And we can see here that in men, 22% of men had diabetes and 33% of women had diabetes, which is a little bit lower than the usual percentage that is around 35% of our patients in internal medicine departments in Israel. What about the susceptibility? So according to this Chinese data and Italian and also from the States, you can see that the percentage of patients with diabetes that were hospitalized during the COVID-19 is around the percentage of every day, meaning that the susceptibility of diabetic patient to be infected by SARS-CoV-2 is not higher. So they are not more susceptible to be infected according to those studies. But we can also see that patients with diabetes had much higher percentage of severe disease than mild to moderate disease, meaning if you are hospitalized during the pandemic, your chances to have a severe disease is higher than non-severe disease. So non-increased susceptibility, but increased severity of the COVID-19 disease in diabetic patients. We can also look in another cohort that comes from Israel, 162 patients, and we see the same picture, higher percentage of severe patients with diabetes. What about mortality? Again, we see that diabetic patients had much higher mortality percentage compared to non-diabetic patients. You can see 35.5% mortality in diabetic patients compared to the 7.2 overall in Italy, and in the States also a higher percentage of mortality in diabetic patients. So they are not more susceptible, they have severe disease, and the mortality percentage are much higher. What about the level of glucose? We know that the higher the glucose level in admission, the higher the infection rate in general. Also here, in this study that came from China, the higher the glucose level, meaning above 180 milligram or above 10 millimole per liter, okay, the higher percent or the lower percent of survival. And the difference here is 11%, meaning that you have to control the glucose level in the admission to the hospital in those COVID-19 diabetic patients. This is very impressive. Even those without diabetes, if they came into the hospital with a higher glucose level, more than 180 or more than 10 millimole per liter, had higher chance, had lower chance to survive. So if we look on the mechanism, one of the explanation is that we have several paths. The cytokine storm that we know that increase in metabolic disease cause insulin resistance that cause hyperglycemia. And this hyperglycemia translates into endothelial dysfunction, platelet activation, and AT3 glycosylation that leads into thrombosis and multi-organ damage. We have also a path of beta cells. We know that there is ACE2 receptors on beta cells that cause to decrease insulin secretion. Lower insulin secretion leads to hyperglycemia and again leads to multi-organ damage. So diabetes, through these mechanisms, cause multi-organ damage and higher mortality. If we look on the treatment of diabetes, and we examine these treatments in two ways, the effect of ACE2 expression in animal studies and the effect of anti-inflammatory of those treatments, we can see that all the treatment have effect of anti-inflammatory except SGLT2 inhibitors. Part of the treatment have also effect on ACE2 receptors. So we really, in our hospitals and in other internal medicine departments in Israel, had protocols that when COVID-19 diabetic patients were admitted to the internal medicine department, we stopped SGLT2 inhibitor and metformin. We controlled the blood glucose into the range between 140 and 180 by basal bolus insulin regimen. In those that were mild hyperglycemic, we used, instead of basal bolus, basal insulin plus the IPP4 inhibitors. And we monitor the glucose very closely due to the fact that higher glucose level translate into higher mortality. Now let's move to obesity. So we know from the H1N1 pandemic in 2009 that obese and morbid obese translate into higher death rates, even without any comorbidity. Just being obese in H1N1 pandemic increase the risk of mortality. Now we saw this percentage that obese patients have higher percentage of hospitalization, but not just hospitalization. We see this in this French cohort from ICU, 124 patients in the ICU, that there is higher percentage of obese patients in the ICU compared to the non-SARS-CoV-2 patients. And those above BMI 35 have higher percentage of, or higher chance or higher risk to be intubated in the ICU. Now, another study came from the US that shows that even BMI above 30 is translate into higher percentage, much higher percentage of mortality, and BMI above 35 translate into higher, much higher percentage or risk of mortality, meaning that obesity translate into higher risk of mortality or intubation. So the next question is, why do obese patients present a worse clinical picture than lean subjects? So there is several explanations, meaning that they have chronic inflammation in the baseline. The obese patients, people with obesity, have chronic inflammation. They have compromised immunity. They have increased risk of chronic disease, comorbidities, and increased risk of infections. Those risk factors translate into higher risk of morbidity and mortality. So in the last few years, in 2019, we published a paper that shows that in obese non-diabetic patients, when you look onto the TNF-alpha and interferon gamma level just in the blood, you see that they have higher chronic inflammation just by being obese. And they have lower IL-10 just by being obese, meaning they have lower anti-inflammatory cytokine and much higher pro-inflammatory cytokine just by being obese. This is a very complicated picture, but if you look on the infection in the influenza virus, it's the same with COVID. The influenza virus decrease the interferon alpha, beta, and gamma, and by doing so, they are shut down in the first few days into the machinery of protection by cellular and immune cells. But after a few days, the macrophage start to produce cytokines in order to protect the body against the virus. So if they produce the cytokine in a normal level, so it's good. But sometimes, mainly in obese and metabolic patients, this can lead to cytokine storm, much higher level of this cytokine. So these are the reasons why obese are more prone to have higher morbidity and mortality in COVID-19 patients. So the next question is, why are obese patients potentially more contagious than lean subjects? And we see from this H1N1 virus, that obese patients have higher and longer viral load compared to the lean patients. And we examined the negativity of the swab test, and we showed that those who are above BMI 30 have longer negativity results compared to the lower BMI of 25, meaning that obese patients have longer and higher viral load in their throat. Now we saw these receptors of ACE2 and the virus getting into the cell through these receptors, and we also learned that in the adipose tissue, the subcutaneous and also the visceral adipose tissue, there is the highest ACE2 expression, meaning if you have higher adipose fat, you have higher ACE2 receptors that may ease the way of the virus into the patient. So what about the vaccination in people? We see also this, that obese patients compared to the lean patients have lower immunity after vaccination compared to the lean patient. Now, if we want to summarize all of this, we can understand that obese patients are suffering from multiple morbidity. They have lower cardiorespiratory metabolic reserves, and they have higher immune hyperactivity, meaning cytokine storm. These two factors combined into severity from COVID-19 infections. And this is the last slide that I want to show from a very, very important, I think, a paper that was published just this week. And in those diabetic patients, they examine the chance to be mechanical ventilated and death within 7 days of admission. And the most important predictor was BMI and glucose level, as we showed. So metabolic disease, diabetes, and obesity are the most important risk factors for COVID-19 patients. And by saying this, I want to thank you for your listening.
Thank you very much, Dror. So yeah, obesity is coming out as a real important and independent risk factor. Do you think also that beside the well-known interference with the immunity, there is also a mechanical effect of obesity on respiration? And so, of course, we know that there is a lot of prevalence also of sleep apnea in all these patients. Maybe it would be nice to go back and to see whether there, you know, in the death, there is also a common risk. So what do you think in terms of interference? Okay, yeah.
Yeah, of course. This is a part of the comorbidities of obesity, you know, the lung disease of obesity that cause the obese patient to be much more susceptible to pneumonia, of course. So this side of the equation.
Sure. Dror, there is a question.
Yes.
So a question from an attendance. Have you looked at underweight patients too? So those with BMI less than 19. Do you have any?
So we didn't have such patients, but of course, it's again the other side of the equation. They have the same risk: chronic inflammation, compromised immunity, increased risk of chronic disease, and increased risk of infection. So it's the opposite side of the equation. They have the same risk, but we didn't have a very low BMI in our department. Okay. But I imagine that it's the same risk.
Okay, thank you very much, Dror. So
thank you.
Let's move to the last talk by Professor Kokorin from Moscow, and he will talk about cardiovascular comorbidities and COVID-19. Valentin, please.
Okay, dear colleagues, I will briefly focus your mind on the cardiovascular complication of the COVID infection. And I decided to highlight only on 5 most hottest, for my personal opinion, topics. But first of all, I would like to say that we should emphasize that cardiovascular diseases are the risk factors of severe course of and outcome of COVID infection, and such diseases like hypertension, like heart failure, previous myocardial infarction or stroke, they worsen the prognosis of our COVID patients. But at the same time, COVID and the virus is affecting cardiovascular system, causing different cardiovascular complications. So the questions I would like to discuss are concerning about diagnosis of this complication. Should we perform ICG to all patients or not? Should we make biomarker tests, lab tests for cardiac injury to everyone? And should we perform echocardiography also to our patients, or just to some indications? The second question concerning arterial hypertension, because as we remember at the beginning, especially of the pandemic, there was a lot of discussion about influence of ACE inhibitors and angiotensin receptor blockers on the course of COVID infection. The third question concerning anticoagulation, which medication in which doses, when and how long should we use in COVID patients? Also, I would like to say a few words about cardiac arrhythmias, how often are they and what are the reasons and how to treat them. And the last question is very interesting and concerning acute coronary syndrome, because many colleagues in different countries noticed that the number of patients with acute coronary syndrome decreased during the pandemic. And now we are discussing what is the reason of that phenomenon. So today we know already the main mechanism of the development of complication, which include dysfunction of endothelium as one of the key mechanisms which leads to macrovascular and microvascular dysfunction. The second very important mechanism is inflammation, and the third one is the direct or indirect injury of myocardial. And all these mechanisms are leading to development of thrombosis is one of the major complications of coronavirus. Thrombosis on both microvascular and macrovascular levels. They lead to development of myocarditis and myocardial dysfunction, which caused heart failure and cardiac arrhythmias. So what we know today for different cardiac methods of diagnosis of myocardial injury in our COVID patients, we know that we should use ACG criteria, absolutely the same one for COVID patients and for the general population and other disorders. We know that baseline ACGs may be not every time needed, not to all patients, but it's necessary for those who had no previous ACG and had some special clinical concerning about the myocardial injury. We know that in patient who was admitted with COVID infection, there was noticed elevation of cardiac troponins and BNP concentration because of two main reasons, because of pre-existing cardiac diseases and also because of acute myocardial injury or stress related to the infection. We know that in patients with COVID infection, like in other pneumonias or pneumonitis, it is suggested to measure troponin concentration only if we suspected type 1 myocardial infarction, or we have some specific clinical grounds, for example, new onset left ventricle dysfunction, but not in all the patients. The same situation is with the BNP measurement concentration. It is not recommended as a routine procedure to all our COVID patients. And also we know that echocardiography, especially at bedside, of course, is a very effective option for screening of cardiovascular complications, but the test may increase the infestation of the medical staff, and we now should prescribe this method only in such cases which will lead to change of medical management strategy. Concerning hypertension, we know that hypertension is a risk factor of the worst prognosis of our COVID patients, but the discussion concerning ACE inhibitors and angiotensin receptor blockers follow to the conclusion that they are even not danger, but maybe positive for COVID patients because of influence on the ACE2 type receptors, and that we should be very careful in treating blood pressure, especially hypertension, in critically ill patients. We mostly should not use intravenous medication and should use traditional algorithm of treatment of hypertension in such cases. We know that there are some factors which could be predisposing factors to the prolongation of QT intervals, such as electrolyte imbalance, concomitant unnecessary drugs, and bradycardia. And we also should remember that antiviral medications, especially hydroxychloroquine and chloroquine, may also increase the duration of QT interval, leading to increased risk of ventricular tachycardias. Also, we always should remember about drug-to-drug interactions concerning antiviral, antiarrhythmic, and anticoagulation medications. And we should repeat ACG during the course of antiviral treatment for measurement of QT interval. The treatment of other cardiac arrhythmias mainly similar the one we use in non-COVID patients, except concerning of usage of amiodarone combining with the antiviral therapy, especially hydroxychloroquine in combination with azithromycin. Coagulopathy is one of the main pathogenesis mechanism and complication of COVID infection. And even the first paper showed very high levels of D-dimer in many patients with COVID infection. And D-dimer is a marker which is associated also with the increased risk of death. Many researchers suggest that in COVID patients, microcirculatory thrombosis is the basis of damage of many organs, which leads to multi-organ failure. And there are explanations. There are the known already mechanism of hypercoagulation in patients with COVID infection, which is associated with systemic inflammatory response, severe endothelial dysfunction, and damage due to exposure to ACE2 receptor, platelet aggregation induction, and stasis due to immobilization of such patients. Also, there was some data showed that in patients who had COVID and massive thrombosis had also increased levels of antibody titers to phospholipids. And I tried to combine a lot of different guidelines concerning treatment of COVID-associated coagulopathy, and what we can see, which was released in the last 2 months, and what can we see that there is an evolution in the view which anticoagulants and when and how we should use in such patients. And almost everyone now clarified that at least prophylactic doses of anticoagulants should be administered to all hospitalized, all admitted patients. In some cases, we should use higher and therapeutic doses, especially in cases of very high level of D-dimer, but in different guidelines, the indication for high doses of anticoagulants is different. We also know that in some cases we should extend the duration of anticoagulation therapy at least for several weeks or months after the discharge from the hospital. And we know that for admitted patients, probably the best option will be to switch the patients from oral anticoagulants who get it in tablets to heparins, at least for the period of admission. And mainly this concerns the severe patients. There is very limited data concerning pharmacoprophylaxis of thrombosis in outpatients care. There are just a few views, but mainly the conclusion is that if the patient is already on anticoagulants, he should continue the usage of these medications, especially oral. But there is no clear data that we should use low molecular heparins outside of the clinics. And of course, we should take in the mind the interaction of anticoagulants with the anti-COVID therapy. That mainly concerns chloroquine and hydroxychloroquine together with azithromycin and also lopinavir with ritonavir combination. For other medications, there is very, very small data concerning possible interaction between the anticoagulants and COVID treatment. And in the end, I would like to say that, of course, COVID is a factor that is disconnecting people, but I'm sorry, the last slide, it is here, but EFIM, of course, trying to connect internists back. And I hope today our discussion, our webinar will be a good step on this way. Thank you for your attention.
Thank you very much, Valentin. Yeah, connecting back. This is exactly what we are trying to do. So there is a question, Valentin, that is a question that I would have also liked to ask you. Do you think that there could be an effect also of confinement per se? So the reduction of physical activity in the effect on the cardiovascular. So there could be also a part of what we saw in terms of cardiovascular complication also related to the change in lifestyle in the last 3 months.
I think that is one of the factors, of course, because the immobilization, we know, is a risk factor for thrombosis, venous thromboembolism, and pulmonary embolism as well. So definitely this is one of the factors. But and I read some papers concerning these issues, but it was mainly discussion, not the scientific paper, not the any trial examining this issue. I suppose, of course, yes.
Yeah, because one of the things that we were discussing between physicians here in Italy, when realizing the fact that the acute coronary syndrome were reduced, was were reduced at the beginning, that once was, there were one positive and negative effect of confinement. One was a negative related to immobilization. The other was positive related to a reduction in stress due to the work activity every day. So, there was a sort of balance between these two.
As I told, this is a multifactorial process, and of course, immobilization is a bad factor, and absence of stress is a good factor. So, but we should also focus on some other measures and things, of course.
Yeah,
well.
There is another question, Valentin, from an attendant, and she asks, how would you consider anticoagulation treatment for a patient on hemodialysis, given the fact that during the dialysis session, this patient received low molecular weight heparin, so therefore 3 days per week?
Very good question. You know, this is even without COVID, very, very hot topic for discussion about anticoagulation in severe renal dysfunction. I will say that for today, data shows quite controversial results concerning necessity of anticoagulants in 8-stage renal failure, because the risk of bleeding in such patient exceeds the risk of thrombotic complications very, very often. So there is no guidelines. There is just a state of art and a personal opinion. I will say that, of course, we should measure the risk of bleeding and the risk of thrombosis in every single case and take a very wise decision for each patient. There is no exact answer on this issue, but as I know, in many cases we use low molecular heparins and sometimes heparin in such patients, not oral anticoagulants, at least in COVID patients.
Okay, thank you very much. So thank you very much to all the speakers. Now we have still 10 minutes for the general discussion. So I would like to just to ask all of you a few questions about drug treatments that has been one of the major issues. So has been asked to, you know, there is a question regarding the most, let's say, the most used drugs in Spain and in other countries for patients not undergoing ventilatory treatment. So, you know, the experience, very short, brief from each of you about what kind of treatment did you use in these patients and how was the feeling? Just no more than 2 minutes each, otherwise we will not be able. So Xavi, you can start.
Oh, thank you. The problem is that now we know more, but we used in Spain, we used this antivirus treatment as the first step, and now we know that most of them are not active. We used hydroxychloroquine and Caletra especially to treat as antiviral in the first step. And in the second step, when the inflammation comes, almost personally, we have a very good experience with tocilizumab and corticosteroids, but given on day 11, day 10, and 12. But of course, we are waiting for randomized clinical trials because these are observational with real world data. And we are now expecting the results of these randomized clinical trials, especially those that combine antiviral as a first step and immunomodulators as a second step.
Have any of you used the ivermectin?
Wow.
The antiparasitic drug?
No.
I have heard that in Spain, I think that is an ongoing study in Navarra, in the north of Spain. But the problem is that you have to achieve a very high doses to be antiviral. And in humans, I think that is not possible, but I don't have more experience than that.
Okay, Runolfur?
Yeah, well, first of all, I would like to point out that, and this has been suggested in the question and answer session, that the WHO has actually taken up hydroxychloroquine again in the protocol because of the retraction of the Lancet papers. I'm not sure that is a wise thing to do because there are other studies that basically suggest the same. Regarding treatments, I alluded to that in my in my presentation, I mean, we used hydroxychloroquine sometimes in combination with azithromycin, and then in the ICU setting we used tocilizumab, and we didn't have the remdesivir available at the time. We haven't had any new cases now for several days, or and no cases in the hospital for a month. So it's not really an issue right now, but we'll see what happens in the coming weeks or months.
Dror. The mic, Dror.
Okay, so in the beginning, those who were in moderate situation, we started to give hydroxychloroquine, azithromycin, low dose azithromycin, and zinc. This triad, and we saw very good results. We had 10 patients, and none of them were intubated. They all had severe pneumonitis, but none of them were intubated, and they were discharged. We didn't see any QT prolongation because, and we followed them very, very carefully. So our experience were very good with this triad, and I know there is a combination study with zinc and hydroxychloroquine. So we will see the results with the adding of zinc. Maybe it did something. After it, we used in several patients Actemra anti-IL-6. When you use it early enough, it's effective, but we had several infections, severe infections with Actemra, that we overcome the infection, but it was severe side effects. We also had remdesivir, but only in the intubated patient, and this was too late. So if you want to give remdesivir, you have to give it much, much earlier. And we started in the last months, we started to give convalescence plasma in early stages. And in some patients, it really stopped the deterioration. It's if you give it early enough. We also measured the effective neutralizing antibody and in the plasma before we give it. So most of the patients have 60% of neutralizing antibody. And maybe this can be an effective treatment also in the beginning of the disease. Those are the treatment that we used. Of course, we used a lot of heparin and low molecular heparin.
Thank you, Dror. Another question, I think one of the last for all of us.
Nicola, may I answer also or not?
Pardon? Yeah. Oh, yes, so I'm sorry. Sorry, Valentin. Sure.
Okay, so as a standard protocol, we used hydroxychloroquine with azithromycin, either collateral with interferon beta. In severe cases, we used biologic agents such as tocilizumab, sarilumab, or Janus kinase 2 inhibitors, and anticoagulants to all admitted patients since the beginning. And we started with the prophylaxis doses, and last month we used therapeutic doses to everyone. And I will say that due to my personal experience, the most visible effect was on sarilumab in severe patients, of course.
Any experience of early triple antiviral therapy? We have never used early. I mean,
we didn't have that, but I based on the available evidence, I think early treatment is really the key in terms of antivirals. You know.
Absolutely. The early treatment. The problem is that the patients came too late to the hospital, and then they,
So last question that I think is very interesting that we can really end with this.
Nicola, just a moment. We didn't talk about about steroids. Steroids is a very interesting story. We had the luck and the chance that we had the opportunity to measure IP10, which is the interferon gamma product. And if the IP10 was high, then we gave steroids, high-dose steroids. And if the IP10 was low, we didn't give it. So it's a tool to decide. And those who have high and we gave steroids, they benefit from this.
Thank you, Dror. So the last question, as I tell you, so from the attendant, so what do you think about the global epidemiology of SARS? So is asked whether it is a seasonal pandemic. So should we prepare for the new outbreak next winter? So I would like to start answering, and I don't know whether we can call seasonal pandemia. I'm pretty sure that it will come out again in winter. But what I'm really scared in winter is this. You know, as soon as the seasonal flu will start, and usually this is at the end of October, at least for us in Italy, any person with fever and cough could have COVID. So unless it is proven is not. So what I'm really afraid is that at that point there will be a rush to the hospital, because now it's coming out that the early treatment of COVID infection is very important. And this is maybe the reason why we are, you know, even in our hospital, the severity of the disease decreased. So I'm really worried about the fact that 1,000 people can access our hospital with fever, most of them with the seasonal flu, but that has to be proven. And so I think that this could be the major problem during the winter time. What do you think?
Well, I'm not sure it's a seasonal pandemic. We have to know what is the source of this pandemic, if it's natural or unnatural. And I think we will have to look on Australia and New Zealand, what happens there. So if we will see in Australia and New Zealand maybe rising of this pandemic in their winter, so we will have pandemic also here. And I totally agree with you. It will be a disaster, because now there is fighting on every vaccine, flu vaccine. You know, there is a shortage of flu vaccine. So we will have two pandemic, and we will have a very hard time. Yeah. But I'm not so sure it's a seasonal disease. I think differently.
Well, it's a very interesting. It's an interesting issue, and well, first of all, in terms of the SARS epidemic, I mean that the illness was much more serious. So I think, you know, one of the reasons why it was curbed so quickly is the fact that people were very ill. They were in the hospital as opposed to being out in the community spreading the virus. You know, in terms of the COVID-19, it's very difficult to predict. We have a very interesting experiment coming up, because on 15th of June, we will open the borders of the country. We haven't had any real infection in the community for a long time now, for weeks. And so it will be interesting to see what happens when we get people from different countries coming in here. And it will be challenging, because individuals that have respiratory symptoms, they will be tested. They may have had COVID-19 before, and they may still be shedding viral RNA. So that's one of the challenges. But in terms of another wave, many people are predicting that. I think it's open. I mean, just like with the treatments, the jury isn't out. We don't know. I mean, it's very difficult to predict.
Well, now for you still checking the patients, or just if patients have symptoms, you are taking the swab?
If they have symptoms.
So you don't know if there is really SARS in the community. If they are asymptomatic, you don't know.
We've been testing every day now, you know, still, and we've had in May, we had less than 10 cases, and most of them had antibodies. Most of them had antibodies already. And now one point that I think is important to make, the tests for antibodies have improved significantly, and now they are very good. The sensitivity is now very high, as well as the specificity, and that will help, I think, in the months to come.
Do you know, because I don't know, do you know whether if there is a decrease in the title of antibodies or not. Are there? Because I'm not aware of any study that describing whether then there is a decrease on time.
We will be monitoring that. I can tell you that the patients that have the most severe illness have had the highest titers of antibodies. But we've been finding now we've been detecting antibodies in almost every case with the new Roche assay, for instance. So but I think we are expecting the titer to decline over the next few months.
So we are measuring this in all the recovered patients, and what we see, there is decline. After a few weeks, the IgG is declining, but we are now checking if there is a B cell memory, because you don't have to have the IgG all the time high. If you have memory in the B cells, so when you will see the virus again, the B cells will produce the IgG. And we just have to have the results now, and maybe in the next time I will be able to tell you what are the results, because this is very important.
We are doing the same.
Yeah. Just an anecdotal thing. My two daughters, 9 and 11 years old, they have an IgG title that is double than mine. They were totally asymptomatic where I got flu. So.
Yeah, all the children are most of the children are asymptomatic, totally asymptomatic.
Yeah, totally, but with very high IgG titles, so that was quite unexpected. Okay, so there are no more questions. We are perfectly on time, 5:30. So we would like to thank you, all the attendants who joined us, and we hope that it's been useful, and that we have shared useful information with all of you. We will keep in touch. We will try to organize again even more focused webinars and meetings like this. So thank you very much to all the attendants, and see you in the next future. Thank you.
Thank you.
Bye.
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 Bye. Thank you.